All right. Y'all know who I am. I'm Mitch Stanway. We're going to be going over the Bumedinst Instruction 6220.9 Bravo. Healthcare Associated Infection Prevention and Control. Again, this is a combination of the 6220.9 Alpha and then the 6600.13, which is Dental Infection Control. Those two are obsolete now. They combine together to make this instruction. All right, so the first part's really not going to be on the test, but obviously the purpose is to establish infection prevention and control programs with each command. Okay, and remember when I said keywords when you're looking at responsibilities? You see CO here, right? Look what keyword is in this. Establish, right? See the word establish, the first responsibility that should be popping up in your head is commanding officer. All right, they establish the infection prevention and control programs. Okay. Concepts of infection control apply to all shipboard and Marine Corps field, medical, and dental units. All right, shipboard and Marine Corps field, medical, and dental units. So any kind of deployment type platform. It technically still applies also to shore MTFs, but they probably don't say that on here because you also get dictated by the state and local policy that sometimes supersedes some of the instructions and policies we have in place. All right, you don't need to know the September 2010, but that is when they all participated in the National Healthcare Safety Network. Okay, so requirements: to have a designated infection preventionist, infection control risk assessment, and annual performance improvement plan. You're going to see the word annual on a lot of programs when it's talking about reviewing each program for effectiveness and changes. It's usually going to be on an annual basis, and it's usually going to be your big hitters, your like safety, infection control, supply. Any of those big ones are going to be affecting healthcare. Okay. Not to go in the weeds there too. Does anybody know what a FTE is? It is a full-time equivalent, right? So there's a chapter that goes over 1.0 FTEs per X amount of patients at a hospital, right? It's just telling you it's a, and they're booked for a 40-hour bookable week, right? So they appoint that amount of people to a unit based off of how many services you're providing or how many people you service. Then that's what's going to augment how many people you get per unit, if that makes sense. So we're going to go over there. You're going to have 1.0 FTEs per command, right? Now it's per a certain number. Once that number goes over that, then you have, I think, 0.8 or another number right above that to where they can give you like a part-time infection control assistant to where 80% of the time they're going to be doing that, and the other 20% of the time they can be doing admin or whatever they're required to do. Okay, so infection control. As we all know, we have it at NDOC, we have it annually, and then as needed. The as needed should probably happen more often than it usually does. Usually we have that when a safety event happens or any new policy comes out, like COVID. We had a bunch of different infection control trainings when that first came out, just to make sure we were up to speed on what's going on. All right, so you heard about a bajillion different BUMED offices this week, right? You need to find a way to help remember all of them. Okay, so your BUMED infection control consultant is BUMED M3/5. Okay, now, remember when I was talking about keywords? Implementation, right? When I hear BUMED and I hear the word implementation, right? I should correlate those two things together. Okay? They provide guidance on the healthcare infection control program, right? So if you know your echelons and how they go, the CEO is not going to be providing guidance. The echelons below him, like the regions, aren't going to be providing guidance. They're going to be taking guidance provided by Bumed, pushing it to us, and then we push it to our sailors and officers, right? So Bumed provides guidance for the Health Infection Control Program, and they monitor implementation and coordination. All right, so here is the FTEs I am talking about. Okay, again, what's up?
Oh, I just have a quick question. I know that whenever we did admin on the first day, the HM1 said that IMS had changed to INS. For the purpose of the exam, is it still going to be N?
Yep, there's only I think 1 or 2 N's that are actually in your advancement stuff. It's like N95, which I think is Surgeon General, which is also Chief of Bumed, and there's one other N, but most of them are all still going to stay M on the bibs. Know that too. I don't know if I mentioned that. Just know anytime those are mentioned, Surgeon General and Chief of Bumed are the same person. So what we'll call that as dual-hatted, meaning they have 2 responsibilities in that position. So those have been green side. We're going to use dental battalion, for instance, right? If I have my CO, he's not just the CO of dental battalion, he's the CO for dental for 2nd MLG. So he wears 2 hats for each of those organizations. Or you have those ones where they're blue and green side for that same kind of concept. So he's the CO of Naval Dental Center and also the CO of 2nd Dental Battalion. Same kind of concept here.
And that's kind of like with Juliet, or EMF Juliet, and what we call the other ones.
Mm-hmm. Yep. Like 20, 25. All right. So at a minimum, in each patient MTF, they should have an IP position of 1.0 full-time equivalent, right? Again, this is talking about, hey, how much are we going to put in staffing-wise for this organization based off of the patients how many patients they are seeing, right? So, for every additional 100 occupied acute beds, an additional ratio of 0.8 to 1.0 FTEs are advised, and then 1.0 FTEs for managing approximately 30 to 40 intensive care unit beds. Okay, again. You might ask yourself, why is some of these less than 1, right? So 1.0 is basically the full day, what you're getting appointed something, right? So if it's a point A, that means they have a 0.20 discount to where they can be doing admin work for those 0.20 hours, if that makes sense, right? So some of your dentists or your providers, they get that kind of discount. So when you're building your med home port team, to where you have time allotted to do admin, because you have to hit a certain amount of bookable hours every week and hit a certain amount of patients to be able to maintain your facility operating the way it is, right? That is how all the funding works for all these MTFs. All right. Freestanding ambulatory care facilities, including DTFs, so dental treatment facilities, must also have recommended staffing of at least 1.0 FTE IP for up to 200,000 ambulatory care and dental visits per year. So know your beds. So 0.8 to 1.0 for every 100 acute care. So know the difference between acute and intensive care. And then 30 to 40 for intensive care unit beds. Hold on 1 second, guys.
Can you go back one second?
You're good.
Do these on the dental too?
Yeah. I don't think I've ever really seen the dental on there, but I can't say it's never going to be on there. But 1.0 for every 200,000.
Is that enrolled patients or seeing patients?
It's for so it's dental visits. So it's dental visits per year. So it's seeing patients. So that's why your IDCs and your PAs, they have like 1,100 to 1,400 patients or something. I think it's around that number to where they have to see that amount of patients per month whenever or at least the FTEs that go towards, or the weighted value that goes towards that. So you get credit for every single time of procedure you do. They have to meet that mark to maintain that accreditation and be able to work in that facility. All right. Definitions. Okay, communicable disease. The illness due to a specific infectious agent or toxic products which arise through transmission of the agent from an infection person or animal or an animate reservoir to susceptible host, right? So your communicable diseases. You remember that is what carried plague back in the day in Europe? Rats, right? What carries malaria? Mosquitoes, right? So it's anything from some sort of animal or reservoir that then contracts and gives that to humans, right? Another one was, I think, swine flu, right? Now, difference between critical, non-critical, and semi-critical. Okay, so I'm going to give you the quick breakdown on that. Non-critical devices are something that is not touching the mucous membranes or puncturing the mucous membranes, right? It's just basically touching the surface. So there's going to be your lead vests, your blood pressure cuffs, the x-ray rings, anything that is not going really inside the body, right? Your non-critical, hold on one second here. Non-critical device, your semi-critical devices, they contact mucous membranes or intact skin, but they don't puncture it, right? So that could be like your bite blocks that you bite down on, or anything that can like touch the inside of the mouth or whatever else, but they're not going deep inside a cavity, all right? Your critical devices, that's like your any kind of surgery items that are going inside the cavity or anything that is puncturing it. So sometimes you have your, that's what I'm looking for. For dental, you have scalers and everything else that's puncturing into that area. That's going to be exposed to blood and saliva. That's not going to be treated as a critical device, right? So it is. So critical is puncturing a mucous membrane. Semi-critical is contacting but not puncturing, and then your non-critical is just touching the surface. What's up?
I was going to ask if a semi-critical device could also be like an aspirin syringe.
Yes. So it's going to go over that. There's a slide here that goes over some more items for that. And what semi-critical basically means is stuff can be high-level disinfected or sterilized, right? So you have that little option there. For dental, for instance, one of the things we use to where we don't have to sterilize it every time is that little bite block you have for panos. We'll purposely put a plastic sleeve on there so that way it's then almost like a non-critical device, or we're just wiping it down after every patient because they're just biting on that plastic. Okay, this one has been on the test right here. Begin each day with a hand wash of 15 seconds minimum, or whatever the latest CDC guidelines advise, right? Again, so for a lot of infection control, we're going to be going from what the latest policies are on CDC, FDA, EPA, and for our SPS stuff, it's going to be AAMI standards, right? Because those are coming from the government just as much as Navy policy, so we had to go by that. As you know, PrevMed does that a lot with some of their CDC guidelines. They kind of have to follow whatever those federal regulations are. All right, this one's been on there too. So EPA, right? Regulatory standards for drinking water. Less than 500 colony forming units. Okay, so what happens, I'm going to give you a breakdown of what this is. If you've ever seen it, we call these millipore tests. Is we have this this container that has this grid on it. So what we do is we get water from every little source on that chair. We put it inside the container. We then put the paddle inside there and get it basically soaked in all that water. Take out the paddle, pour it out, put the paddle inside there. We go to the lab, put it in the incubator for 48 to 72 hours. When we pull that out, we're going to be looking at each grid square, and if a spore pops up on there, it's count as, I believe, 100 That's like 10 colonies or 100 colonies, right? So if it's filled up all the way and it's more than 500 colony forming units, we know that there is bacteria in the water, and the water is not safe to be used on patients, right? So all waters had to have less than 500 colony forming units. To make you feel safe, most of the time there's nothing on there. Most of the time. But that's because we treat our water also with the tablets. We call them ICX tablets to make sure that it's kind of like almost using iodine on there. We're trying to make sure that the water is at least being treated before being used on a patient. Why we also flush the lines at a minute at the beginning of the day and 30 seconds in between patients for those exact reasons, so that we're never leaving any kind of bacteria or buildup inside the water lines. Yep. With stuff that basically ruins chairs anyways. We call it Sterilex. I actually got them to get rid of the powder way back when because I realized the powder was corroding dental units. It was a chemical that was building up inside of that unit and causing the machine to break down. So now they use a liquid that flows a lot easier, still causes some buildup, but it does what it does to basically shock all those lines to get everything out of there. It's kind of like pouring, what's that stuff you pour down the drain to clear it out? Yeah, same kind of concept. You're just doing a quick flush of everything out of that line. All right, unit dose. We know what unit dose is, I hope. So unit dose concepts, quantity of material supplies required to treat a single patient. You will know what unit dose is when you're prepping for Joint Commission, if you have not already, right? All your unit dose items have to be labeled with inside your drawers, so when Joint Commission comes through, they're able to see that and saying you're not keeping anything over that in your drawers. Now there are some exceptions for like dental. We have like fluoride varnish. It would be kind of dumb for us to only keep one fluoride varnish in the drawer at a time when we're using it with every patient. So we at least try to keep a day's worth to make sure we're going through there and not keeping too many on hand. Okay, so I talked about this the other day, and you guys were talking about the disposal method for needles. As you see up right here, one-handed scoop technique is recapping safety device for there. So that is how you're disposing of it. You're doing a one-handed scoop technique to close it up, and then you're popping it up in the sharps container. Okay. Oh my gosh. Test question. These two right here. Okay. Actually, I don't know why it says that, because per manufacturer's recommendation is not an answer choice on the test when they throw that question on there. It's going to be weekly. Bro. Hold on one second. Sorry. People keep exiting and going into this call. All right, so flush water and air for 20 to 30 seconds after each patient, right? So HV is your high volume evacuation, right? So what we do is during the procedure, we'll use that to suck up any amalgam, saliva, blood, anything else during procedure. So it's probably the device that gets the most amount of bacteria and grossness during a procedure, right? So it's the big hose one that is like this, and they hold it like this right inside your mouth to suction everything up. Now you have Isolite, which is better, to where it already suctions for you the entire time, but those are bougie type devices. If we're going basic, we use the HVEs, because this instruction was probably written before we got Isolite. You have the HVE that usually just sucks everything up, and because of that, all that stuff can get built up in the line, and that's why they have to flush the HVE system at least weekly. So every day, you're flushing the water lines at the minute at the beginning of the day, 20 to 30 seconds between patients, and then each week, you're flushing the whole entire system. They call it TurboVac. So it's like Drano, but it's not as much chemicals as Sterilex. It's just a quick flush to where you're just having water constantly run through those lines. Yes, I'm saying that because it's in the instruction and not on this slide. 1 minute at the beginning of the day.
Okay, so my non-dental brain, when you're getting a cleaning done, they have a little thing they like hook on your cheek. That's what we're talking about, right?
That one's a low volume evacuation. So that one, yes, it's an evacuation system. But the high volume one is, anybody ever had a filling done? All right, so when you have a filling done, you'll have this tiny one they'll put on your cheek right there, but they have a big one to where the tech will be right there while the dentist is there with the handpiece, and it's just sucking up all of the amalgam, any blood and saliva that pops out right there. It's just a bigger evacuation system.
It has a little tank thing.
There's no, it's still attached to the chair like everything else. You have, so I don't know if anybody can visualize this. You have this little stand here that's right next to the assistant where it has all these holders with things in it, right? So they have one that has an air water syringe, one that has the low volume evacuation, and one that has the high volume, right? So we have one that sprays water for trying to have you rinse an air to dry the area. We have another one that does it to where it's constantly suctioning your saliva so you can breathe, which is your low volume. And then we have the high volume that sucks up all the big chunks or any kind of the stuff that needs to be sucked up right away and quick with the high volume evacuator right here. Okay, I know you guys can't see that. So, because I want you guys to see this. Dude, he's going in and out of the call. If I can get this mouse to actually work for me, we're going to drag this bad boy over here. All right, so I know you guys have seen this on the test, where it's going to be talking about alginate materials and how you disinfect alginate materials or impressions. All right, so if anybody wants to kind of give you a quick dental lesson, any of you guys have ever gotten a bite guard or a night guard or any kind of extra appliance, what they do is they come in, they sit in the chair, the dental tech will then pour up this mixture of powder and water, mix it up. This is the alginate material. They then go ahead and have that patient bite down to get the anatomy of the teeth. They'll disinfect that. They'll take it back to the lab, and then they will go ahead and pour a die cast material in there so where it hardens as a cast for the teeth. Once that cast hardens and they separate it, they then form a piece of plastic down on there to make your guard. They'll cut around it. They'll smooth off all the edges. They'll have the patient try it on. And then there's your appliance, right? So in that process, there's bacteria involved because you're going inside the patient's mouth getting that impression, right? So they have to disinfect it and make sure when they're throughout the process, they're separating those areas so they're not spreading bacteria through that, right? So again, I like to say everything that is the same, pay attention to what's different. The only one that is different that does not have diluted sodium hypochlorite is your zinc oxide and eugenol impression paste, which is only treated by iodophores, but iodophores treats all of them. Okay? Sodium hypochlorite is like a bleach type solution, but iodophores is the big one you need to know for infection control in the dental laboratory. Say again?
You said the zinc oxide?
Yeah, the only one, so this one only has iodophores. So these ones all have iodophores and have the diluted sodium. Oh. Sorry, I messed up. And then these three here have complex phenolics also on there. So only three have complex phenolics, and only one has just iodophores as this treatment. If I was trying to study, I would pay attention to that. The big things that stand out that are different. So polysulfide, silicone, and polyether, which using it on the test, and I'm telling you right now, the ones I've seen on the test is going to be your alginate and your zinc oxide and eugenol. Okay, this form right here is mentioned on your bibs, or usually on the test, so please know it. All right? All this is a lab work authorization form. Okay, so the minute we get your impression, we're going to do a lab slip where we're marking out what kind of device we're doing, if it's going to be a night guard or a bleaching tray. We'll then put your information on there. And what we use, because sometimes we have to send this stuff off, ironically, I guess I'm thinking of it because I wasn't here, we send it off to Norfolk for their dental lab to where they go ahead and build those appliances and they would send it back to those units. I think it's Norfolk or Portsmouth. It might be here. Okay, because I remember way back when I'm Dahlgren, I would have to order it from there to have them deliver that device back to us. But they use that lab slip to kind of show what needs to be made, and they have a basically transfer of work to them so they know exactly what we're requesting. Okay? This is where you're also filling out what you did for disinfection for the device, right? Anything dental lab related, you just need to know this form. DD form 2322. Okay, and again, I was talking about making sure you're not spreading bacteria. So just like in SPS, you're going to have 3 different work areas. I've seen this as a question too. You're going to have the receiving area, production area, and production area for repair works, all right? Give you a visual receiving area. We bring the impression back from the dental treatment room, bring it back to this one room right here. We've already sprayed it while we're in the dental treatment room. We put it here, we rinse it off, because we don't want to mix the chemicals or anything else. And now we are going to start pouring the cast material, and then we're going to go to the production area where there's a grinder, where we're going to be forming up that appliance. And then the repair area is sometimes those casts break, or sometimes we have to fix the appliance itself, so we have to smooth it all down, so there's a separate area for that. I don't know where the other part is then. I guess it's in another chapter. Maybe it was in the 6280. There's a slide that shows each of the different examples for your semi-critical, critical, and non-critical devices. And it goes over the HV saliva ejectors. Okay, so infection control and dental radiography. Okay, so this is what I was talking about where we had that plastic sleeve. So use a disposable panoramic unit bite block cover for each patient. I'm telling you right now, most of them don't have disposable bite blocks. They have the regular ones that cost a lot of money. So we don't have to create more work, what we do is put a plastic sleeve over that so that we're just having to dispose that between each patient. Okay. Same reason why we do that on our saliva ejectors and everything else too. If you've ever seen that, we sometimes have plastic hanging over all of those the air water syringe and all those ejectors, so we don't have to keep wiping down so much between each patient. Okay. When disposable covers are not available, must be cleaned and heat sterilized between patients. Okay. Dark room, don't worry about it. We don't do dark rooms anymore. It's not on the test. Dark rooms was before we had digital x-rays. Okay. If anybody's seen Stranger Things, that's what a dark room is. It's a little red room where they're developing exposing the pictures. All right. Your x-ray chair. Okay. Disinfect at least daily and visibly contaminated. Your x-ray chair what device do you think an x-ray chair would technically be considered? Non-critical, right? Now, for those dental techs that know, those cavity wipes are high chemicals, meaning that no matter what, they are slowly destroying our chairs, and why they get destroyed faster than the life cycle that those chairs are made for. Okay. Also, because it seems like I was baffled that these guys didn't know the answer last week. Why is contact time important for the cavity wipes?
Because they are carcinogenic.
Okay, but what's the difference between letting it sit there for 2 minutes compared to letting it sit there for 3 minutes?
3 minutes is the time it takes to kill the bacteria.
So if you look at the instructions on the bottle, 2 minutes only kills certain bacteria. 3 minutes kills even more bacteria. So basically the time you leave that material on there. So we use the spray wipe spray method or the wipe discard wipe method. So before you're doing that wipe away or discard, you have to let it sit on there for at least 3 minutes. If you only leave it for 2, it's only killing certain bacteria. So the longer contact time, the more bacteria that cavity wipe destroys. So information for y'all if you didn't know that, but it will literally say that on the cavity wipe container. All right. Any questions about infection control? I see H1 Martinez is here, meaning that you're going to have some more environmental safety and PresMed type stuff to go right along with this.